I think there's no doubt that the LDL story is pretty well established. I mean, the causality of LDL cholesterol in atherosclerotic disease is very well supported by a whole range of data. We've seen unequivocally for now more than a quarter of a century that lowering LDL cholesterol via a range of different agents in different classes reduces cardiovascular events. And yet we continue to still ask the question, are there going to be other lipoprotein targets that will, one, be driving cardiovascular risk and then be an important focus for development of new therapies? We've spent a lot of time thinking about whether HDL might be that factor. I think it's fair to say right now there's a lot of attention both with regards to lipoprotein(a) and triglyceride-rich lipoproteins. And triglycerides have probably kind of gone in and out of favour in terms of being a cardiovascular risk factor. There's no doubt right now that the population studies and the genetic studies absolutely implicate triglyceride-rich lipoproteins in the disease process. We know that hypertriglyceridemia is going to become a much bigger issue as the world becomes more overweight and insulin resistance, type 2 diabetes. We are going to see more patients with high triglyceride, low HDL cholesterol. And we know that patients treated with a statin with high triglyceride levels have a higher residual risk of clinical events. So there's going to absolutely be a need to look at how do we target triglycerides and will that reduce cardiovascular risk. So we've struggled over the years with the PPAR agents and with niacin agents that have had variable results, certainly have variable tolerance, and no real clear message that lowering triglycerides with those agents works. Interestingly, with the fibrates do seem to reduce cardiovascular events in patients with high triglycerides. Not necessarily because they lower the triglyceride level and that relates to the benefit, but they lower the risk of an event regardless. And so it really opens up that whole concept of, is triglyceride targeting more important than triglyceride lowering? Is identifying the patient with hypertriglyceridemia that we think has more modifiable disease and then hitting them with the right kind of therapy, the right way to go. And so fibrates are one way to go with that. We've seen really exciting results of the Reduce It trial, 4 grams of EPA, lowering cardiovascular risk by 25% in patients with ASCVD plus high triglyceride levels. Interestingly, triglyceride lowering again doesn't appear to directly correlate with the degree of benefit. So again, it's not about triglyceride lowering, it's about triglyceride targeting. And that will become important as we go into the next wave of therapies where we are going to use therapies that are specifically developed to actually lower triglyceride levels. They're going to target factors that regulate the metabolism of triglyceride-rich lipoproteins, whether that's apolipoprotein C3, whether it's the angiopoietin-like proteins. And we are going to see those agents will only lower triglycerides. Whether they translate to a cardiovascular benefit remain to be seen.